My job in the next hour is to really take you through some of my research interests to explore the link between air pollution and heart attacks. And what I would like to hopefully convince you that there is a link. I would have to take you through some of the work that we've done showing that there's a link in the mechanism. And finally, we can look at some of the approaches that we've taken to try and limit the damage that we can cause through heart attacks. Before we start talking today about heart attacks and air pollution, we have to talk about what a heart attack is, and different people have different views. But this is a movie clip that the BHF used to sort of publicise the symptoms of heart attack, and it comes over very well. So I'm going to shut up now, and I don't know if we can get the volume up a little bit.
You're here to find out what it's like to have a heart attack. Well, we don't have much time because with heart attacks you never do. Well, let's start with the first symptom most people think of. Yes, chest pains. Well, we've all heard of the classic chest pains, but it may not always be that severe. It could be a bit of tightness or discomfort in and around the chest. No doubt you'll shrug this off. I mean, slight chest discomfort, tightness, not worth worrying about, right? Wrong. What if it spreads to your arms? Still not convinced you're having a heart attack? Well, what if you feel dizzy, lightheaded? Oh, still thinking, don't make a fuss. What if it spreads to your neck, to your jaw? You're probably thinking, tough it out, it will pass. What if it doesn't? The longer you leave it, the more your heart dies. How about difficulty breathing? Rising panic, sweaty, clammy. Could be indigestion, last night's curry. Stress. But what if it's your body telling you to get help? Don't kid yourself. If you're having chest pains or discomfort with any of these symptoms, or even if you're feeling unwell, dial 999. Now this may surprise you. The ambulance service would rather see you and discover it's not a heart attack than arrive too late. Every second counts. I know you think you feel embarrassed if it's not actually a heart attack, but imagine how you'll feel if it is, and you left it too late. Imagine that.
So, a very graphic description there from Stephen Burkoff. Do you recognise Stephen there from some of the movies? I think it's absolutely fantastic exposition for how heart attacks can present. It's a beautiful example of also discussing, I don't know how to do it again, a beautiful example of how people can think about it, put it off, how the different symptoms can present. So that's the rather dramatic presentation that a patient that comes to see me, very often in the middle of the night, with a heart attack. But what causes the heart attack? The patients clearly are suffering and it's very unpleasant and ultimately can actually die from a heart attack. But what actually causes it? Well, the trigger of a heart attack is what you've got up on there on the screen. On the left-hand side there, you can see a heart artery, a coronary artery that's blown up to a very big magnification. And in the base of that artery, you can see a mushroom of a blood clot erupting through the surface of what's called an atherosclerotic plaque. And atherosclerotic plaques are fatty deposits in the artery. And these are quite common actually, and I'm afraid probably the vast majority of the audience will have some of these plaques, and I'm including myself in all of this, will have fatty deposits in their heart arteries. But sometimes they cause problems, they burst and cause a blood clot to form. And that blood clot, when it forms, it blocks off the entire artery. And it's the blood clot that stops the blood supply to the heart and causes the heart attack. And that's what causes the symptoms, because that part of the muscle is not getting any blood to it, and it's very painful. That muscle is slowly dying, and that's the pain and the symptoms that patients get. So when I come in the middle of the night when they have a heart attack, this is what I see, apart from the patient who's looking a bit grey and sweaty on the table, is that we do an angiogram, and that's where we put a tube, a catheter, through the wrist to the heart, and we inject some dye, X-ray dye, that we can see the blockage in the artery. And what you can see here is a blockage within the artery, and it's sort of sawn off, if you like, at this point here. This is the catheter. This is the artery, and this is where it's sawn off. Now, what we tend to do is put pieces of equipment through that catheter so that we can see or restore the blood flow. So what I've done here is actually put a little wire through that blockage. You can just about make out the wire at the beginning of the sequence. And what you can see is the dye is now starting to get past the blockage, and you can probably see that there's little lumps almost in there, and that's the blood clot that's sitting there. And ultimately what we'll do is put a little stent in and repair that area of damage, and as you can see, that's the final result, which is usually quite gratifying. You've got the artery open, and the patient immediately says, usually to you, "God, what have you done? I feel so much better," and relieves the symptoms and the pain. And that is quite a dramatic presentation that we get with a heart attack. And it's all caused by this fatty deposit bursting, a blood clot forming, and the blood clot then blocks off that artery and stops the flowing of the blood to the heart. So I started out when I came to Edinburgh. It's probably 20 years ago now, Jonathan, actually. I came to Edinburgh. I started to get interested in what we can do, what controls that blood clot forming in that heart artery. And with Nick BOON and David Webb, who were my mentors at the time, we developed what I call a blood vessel stress test. A bit like when you're doing a stress test on your exercise gym. What we did was do a blood vessel stress test, and what we actually did was lie people on the bed, and then you put a little needle. This is actually my forearm here, so I put my body on the line for my research here. So there's a tiny little needle. It's a bit like acupuncture, but it sits in the artery of the arm, and through that we infuse various substances of interest. And those substances usually make the blood vessels relax, and those substances also release a protein called tissue plasminogen activator, or TPA for short. And TPA is like a guardian protein. It sits in the cells that line the blood vessels. And when a blood clot forms and blocks off your artery, it releases this TPA from the pool within the cell to try and dissolve it, because normally you shouldn't have a blood clot in your artery. You can have a blood clot outside your artery to stop you, for example, bleeding to death, because you don't want to do that if you've just been attacked by a tiger or a fellow hunter or anything like that. You need the blood to clot off and stop you bleeding to death. But when blood clot forms inside an artery, it's not usually needed. So it's quite a clever idea to put clot-dissolving proteins on the inside lining of the blood vessels. And so what we did with this vessel stress test is to infuse drugs that stimulate the lining cells and see how they make the artery relax and how they release this TPA, this guardian protein that dissolves blood clots. Because if your artery relaxes a lot and releases lots of clot dissolving, you can clear your own heart attack. And indeed, that does happen from time to time. And in fact, one of the treatments before we did angioplasty, which is the movie that I showed you, was to use TPA as an injection. And we still do that from time to time to dissolve the blood clot in the heart arteries. So one of my first research fellows is Ingi. She's from Reykjavik in Iceland, and that's where she's the director of the heart centre there now. But she came to work with me, and she used some particular proteins, was able to demonstrate that we could make the arteries relax and release this clot-dissolving protein. So one of the first questions she and I asked was, well, who has abnormal, unusual, what we would call medically dysfunctional, so not working properly, blood vessel relaxation and release of this clot-dissolving protein? So I met Jonathan one afternoon, and I got thinking about maybe we should look at smokers. Because smokers, we know, are much more likely to have a heart attack. And the reasons for that, people do discuss. And we thought that maybe this might be the reason why. So another fellow of mine, as you can see, my research fellows are generally very happy people. But this is Ninian. He's now just got a job in Glasgow. At the Southern General through there as a consultant cardiologist. But when he worked with me, we looked at, do smokers with this clot-dissolving protein, do they release as much of this TPA? And what he demonstrated quite dramatically is that no, they don't. And when they have a heart attack, or have a stimulus, should I say, they don't relieve of much of this clot dissolving protein, and actually the blood vessels are a bit more rigid and they're not as flexible. So that might be why this caused a problem. And indeed, serious Simon Robinson here is a bit more serious. He's a consultant cardiologist in Canada now. But when he worked with me, we looked at a group of around 100 patients with heart disease, because we wanted to study not just smokers, but patients with heart disease. And we looked at those, we did the vascular stress test on 100 people, and those that who released the uppermost amount of clot dissolving protein did the best. And they seem to have less problems with future risk of heart attacks and problems like that, whereas those that released very little of this protein got into trouble, and they seem to have more events. Now, of course, this vascular stress test I'm talking about is in your arm, and of course the heart arteries is something very different. This is actually an example of someone with a bypass graft, so this is quite a gross example of a big bypass graft, and you can see a huge amount of thrombus, just tongue of thrombus sitting in their bypass graft. But so having done it in the arm, we wanted to then do it in the actual heart circulation. Now, as you saw, we lay people on the bed and stuck needles into the arm and put bands around them to measure the flow of blood. We can't quite do that with the heart, but what we can do is use some quite sophisticated equipment called intravascular, ultrasound and Doppler. Now, these are miniaturized cameras, if you like. They're about, as you can see from the top middle panel there, that's the Doppler wire, which is an incredibly tiny, thin structure, 14 thousandths of an inch across, which has a crystal on the top, on the end of it, which is an ultrasound probe. So it's all microscopic little ultrasound probe. And the catheter below it, which often sits over the top of this wire, is an IVUS catheter, which is able to take, not just measure the velocity of blood, but also take pictures of the artery itself. That's about 1 millimetre across. So we can pop these fellas down the artery, and we can measure things like blood flow, which is the bottom right-hand panel there. And in the top panel, you can get a cross-sectional picture of the artery and the fatty deposit within it. And actually, we can reconstruct that if we pull back the ultrasound probe with a mechanical device into 3 dimensions. So we can measure how much of the fatty deposits are in the artery, in the heart, and we can also measure how much blood is flowing down into the heart. And so we asked the question, can we do the same experiment we did in the arm in the heart arteries? And the answer was yes, we could. And I won't bore you with all the validation details of doing that, but it was quite complex. But this was one of the first big challenges, I think, that I took on. And so, having discovered this about smokers, we wanted to perhaps see whether smokers also have problems in the coronary circulation. Now, I have to say, not very many of my patients are usually nuns, and I don't know many of them that smoke, actually, but we did study patients who were coming through our laboratory, catheter laboratory, for reasons they needed an angiogram because they're having chest pains and things. And we measured how much disease they had, and we also documented how many of them were smokers, how many had were non-smokers or smokers. Now, when I ask someone, do you smoke, they don't always give me a straight answer. So when I say ex-smokers, we have to sort of put a question mark over that, because they might not want to confess. But when you look at this, we looked at this clot-dissolving protein across the heart circulation, the coronary circulation, and we're able to see exactly the same picture that we saw in the arm circulation, in the heart circulation. So if you smoked, you didn't release as much of this guardian clot-dissolving protein, your arteries didn't relax as much, and therefore you would predict they'd run into trouble, as Simon found out when he studied them in the arm. And actually, there is a slight paradox about smoking. I did think about whether I should share this with you. I don't know how many of you smoke in the audience. You may get some cold comfort to know that smokers, if you actually look at how many of them die when they get to hospital with a heart attack, their death rate is lower than if you don't smoke. Now, there are many reasons for that. One of them being that the people that smoke get heart attacks younger, so they're less likely to die because they're younger people. So if they didn't smoke, they might not even have come in the first place. But one of the other things that we found was that if you look at studies when you use TPA as a drug to try and dissolve the clot, it's much more effective in smokers. And that again sort of reinforces our view that smokers probably get heart attacks because they don't release enough of their own clot-dissolving protein. And therefore, when you give it as a drug, they respond much better to it, and therefore have a much better outcome. Now, so far I've talked about smoking, you'll have noticed, and the title was air pollution. Well, smoking is self-induced air pollution, I would argue. So how do we get onto air pollution? Well, this is a tale of two Nicks, and I did suggest we call this Mills and Boon, this lecture, and people thought no one would turn up, so perhaps I'd change the title to air pollution and heart attacks. But essentially, Nick Boon, who I mentioned was one of my mentors, went on a train journey, so this is a close encounter of a different kind. He went on a train journey from Edinburgh to London, but on there he met some respiratory physicians, chest doctors, who had an interest in air pollution, and Nick was telling them about my work with smoking. And they said, well, you know, smoking, air pollution, very similar. Maybe we should think about doing a project. So out of that romantic interchange on the train was born Nick Mills, as opposed to Nick Boon, so hence the Mills and Boon. And we wrote a grant together to get Nick his first project, which was on air pollution. So I better tell you a little bit about air pollution. And certainly in urban environments, the vast majority in the UK, the vast majority is driven by this activity of cars. Now, many people say to me, well, air pollution is not as big a problem as it once was, David. And they're right. Back in the 1950s, before I was born, of course, there were huge problems with smog, and then the Clean Air Act came in, and that dramatically suppressed that and made a big change for the good. And now, if you measure air pollution, and the measures you'll probably start to hear about this evening relate to what we call PM10. So that's particle matter that's less than 10 microns in diameter. So these are quite small, 10 microns in diameter. And when you measure the mass of that per meter cubed of air, that's the level of air pollution that we were getting back in the 1950s, was 130 micrograms per meter cubed of air pollution. And today, we get down to an average of around 20. So it must be a lot better. The difference in those 50 years or so has been that we've gone from 2 million cars to 28 million cars and rising. And actually the number of particles in the air has gone up dramatically because what happens is that when particularly diesel engines generate exhaust, they produce really ultrafine tiny particles, not PM10. We often talk about PM 2.5 and even PM 0.1 because they're nanoparticles. They're really very tiny and they get in the air. Now, just to get your head around how small these are, if you were to compare a football to the moon, that's the same size as an air pollution particle to the football. So it's that fold of difference. So they're really, really tiny. So because they're really tiny, they don't have much mass. So actually when you weigh the amount of pollution in the air, you actually might have more particles but less mass. You see what I mean? Because they're so small. And this is the sort of convention that we have. We talk about coarse particles, fine particles, and ultrafine. And it's the fine and probably the ultrafine that come out of car engine exhausts, and particularly diesel exhausts. And these are the ones that we get most anxious about potentially causing air pollution. Of course, there are gaseous air pollutants, and we could talk about nitrogen dioxide, sulfur dioxide, ozone. But today I'm just going to really focus on the particles because that's where the biggest and strongest link is to heart attacks. Now, the evidence is out there epidemiologically. So when people look at national data sets of who dies where and what happens to them, they come up with these statistics. The statistic in the middle panel there is telling you that in America, this is taken from 90,000 women who were tracked and followed up over 5 or more years, their risk of developing heart disease went up the higher the background level of air pollution where they lived. So they looked at where they lived, got their postcodes, or zip codes presumably, and then looked at their monitoring stations in the vicinity, and then looked at whether they had heart disease. Now, there are various factors that might track with that, and there are confounders, because this is epidemiological research. So you might argue that maybe the poorer people lived in the most polluted areas, and we know that social deprivation is more linked to more heart attacks. However, you could argue that maybe that link is caused by air pollution. Who knows? But certainly there was evidence out there that there is a link, and this is even at levels that you would find in Edinburgh, relatively low levels, and we'll come back later in the talk to about pollution levels elsewhere in the world. So air pollution levels seem to have a link with causing heart attacks. But not only does it cause the number of heart attacks, there's also been some studies, this is from Austria, where they asked people what they were doing in the hours before they had their heart attack. And you're 3 times more likely to have been in polluted traffic in the hour, 1 to 2 hours before you have a heart attack. So there seems to be a link that actually being exposed to traffic might actually precipitate and trigger a heart attack. Now, it might be road rage perhaps, it might be various other factors, but actually being in the presence of road traffic does seem to be a trigger. And when you look at this globally, because people say to me, David, surely this is not a huge issue. If you look at this globally, this was the Global Burden of Disease study published in The Lancet a couple of years ago. If you look at the top 10 causes or contributors to the burden of disease, air pollution is in 3 of the top 10. Some of that, of course, is self-induced air pollution, as I like to call it, smoking. Some of it is cooking in third world countries, indoor cooking. But ambient particle matter is number 9 on the list. So air pollution is a huge burden, and some of the World Health Organization have estimated between 3 and 5 million deaths a year are caused by air pollution. So it's a big problem, and it does seem to be epidemiologically there's a link. But my question was, what's the link? How does it do this? What's the mechanism of causing this to really make... You can make these observations, but you've got to have a link that really makes you understand and believe the association. So I went with Nick, or the Nicks, and of course, if you're going to do air pollution research, you've got to make sure you find a nice place to do it. So this is one of the first trips that I went to Umea in the north of Sweden, which has very little air pollution, as you can see. I actually packed my family up along with me here. That's my 2 children at the front. But this was the first year or 2 of our collaboration that we worked with the Swedes. Now, I'd like to point out Thomas Sangström here and Anders Blomberg, who are professors of respiratory medicine at Umea University. Now, why did I go to Umea? What was so specific about that? Here you can see Nick and Simon. Well, they have a unique exposure facility there where they study the effects of air pollution, and particularly diesel exhaust engines. And they had an interest in asthma because, of course, people are very worried about air pollution causing asthma. But when they were doing studies of air pollution and asthma, they realized that people were dying of heart attacks, not from asthma attacks. It was heart attacks they were dying from. So they were starting to get interested in cardiology and heart problems that might be linked. And, of course, we were just getting interested in the reverse direction. So we got together. And this is their diesel engine here. This is a tractor engine. Of course, it's a Volvo. You can see the exhaust here pipe coming out and goes out the window out the back there. You can just about make out a tiny little tube there that goes into this. And it passes through this wall into this unsuspecting patient's chamber. So this actually goes into the chamber here. We dilute it. You'll be pleased to hear we dilute down the diesel exhaust several fold. The British Heart Foundation, who funded this research, the PR department did question whether I was sane at one point. I like to highlight to them that the amount that we put into that chamber, remember the meter cubes that I talked about earlier, and those were average levels, okay, average levels. In the chamber it gets up to about 300 micrograms per meter cubed. Now do remember that number because I'll come back to it, 300 micrograms per meter cubed, but that's a peak. And the numbers I showed you were daily averages. So if you actually walk down the side of a busy street, that's the sort of levels you can get exposed to, and I'll show you that data again later. But the BHF, I did point out to them that since I was coming from a very nice leafy Edinburgh and travel down to London, to go into central London to sit on their grant committees, the pollution I was exposed to outside their front door was probably the same as what's going on in the chamber. Just to highlight to them, I wasn't really doing anything questionable. But what we did was do a series of studies where we exposed healthy volunteers and patients in this environment where we can control and regulate exactly what we're giving them and see what it does to their blood test, their blood function, their blood vessel function. So we did our vascular stress test, and just as we saw with smokers, if you got exposed to diesel exhaust, the amount of this clot dissolving protein you released was less than if you were exposed to just normal filtered air. And this was a crossover, so the patient came 2 days. They actually weren't told what they were given, and they actually ran the engine the other side of the wall without exposing them as well, just to fool them. So they didn't know what they were getting. Some have suggested they might smell the difference, but it's pretty pongy in there. But they monitored the environment very carefully, and so each person acted as their own control, and you can see quite nicely that it reduced the amount of this guardian protecting protein. Now, one of the things that people say, well, this is all well, this protein, David, but what about the actual clot itself? Now, one thing I wouldn't do ethically was stick a clot in a blood vessel in a person, because that would be a bit challenging. So the nearest we can get is this thing called the Bademan chamber, which Juan and Lima Bademan generated, which basically is a model of blood vessel injury. And again, you can see our volunteers are very willing and happy individuals. And what they do is they lie in a bed, and we take our blood just through a drip, and then we pass it through these 3 chambers here. And in the floor of the chamber is a strip of pig aorta. We get it from the abattoir. So the bacon sandwiches go right, and the aortas go left. And the aorta is a blood vessel, which is the main blood vessel in the body. And we just strip off the inner layer to mirror that lovely looking artery that I showed you at the beginning of the talk, where there's a bit of a rupture and a burst. And so we have a very raw area. And we line this on the bottom of the chamber and then allow blood to flow over it. You'll be pleased to know the blood doesn't go back into the person. It goes into a bucket, and they lose about 50 mils of blood, so less than half a glass of wine. But in the process, it generates a blood clot, and you can see a blood clot here. And actually the rheology, or the blood flow properties that goes through these chambers, is meant to mirror that what you'd expect to see in a heart artery. The amount of shear stress on the wall, the physical properties on the wall, mirror that of a heart artery. So we can quantify how much blood clot you actually produce. And this is Andy on his phone. Andy's about to become a consultant cardiologist down under in Australia. And he did the Bademan chamber studies in people who had been exposed to filtered air or exposed to the diesel. And what you can see is that the amount of blood clot that was formed seemed to go up in the chambers. So when you were exposed to the diesel, you got more blood clot. So not only did your blood vessels not respond well, the blood was a bit thicker and more likely to cause a blood clot. Now, ultimately, what I've shown you so far is in healthy volunteers, but we were quite keen to know whether the same was true in patients. And so we did another study in Umea where we took patients. Now, patients sometimes can get problems with chest pains and things, so we wanted to monitor the heart very closely. So we used a very special heart monitor. And as you can see, I'm modeling here the heart monitoring equipment. And the heart monitoring equipment basically records electrical impulses from the heart. And if the heart gets stressed, these electrical impulses give a particular pattern. And it's what we call ST segment depression. I won't bore you with what ST segment depression means, but basically, if you can imagine a barometer of stress, when the heart gets into trouble, it sinks and it struggles to get enough blood. So we use this as a measure of how happy the heart is, whilst these patients are doing a little gentle exercise on a bike inside that chamber that I showed you. And when we looked at the heart stress in these patients, it was much more marked when they were exposed to the diesel. So in patients who are vulnerable to heart problems, actually being exposed to these diesel exhaust was not a good thing for them. They didn't actually have any pain, I have to comment. They didn't have any angina or discomfort. This was really a sort of a bit of heart stress that we could detect that was quite subtle. So obviously it wouldn't be ethical to put through any discomfort or what have you. But this was what the monitor came up with, that we were able to detect that the heart really was quite stressed. And again, the clot dissolving protein that I've showed you is also suppressed in these patients, mirroring what we saw in the healthy volunteers. So really quite dramatic findings. Now, one of the things that people say to me is, David, you know, you've put them in a gas chamber, haven't you, and you've pumped in some diesel exhaust. You're really not surprised it's not good for the body. How relevant is that? Now, I've told you that the pollution levels inside are actually the same as you get next to a busy road. But one thing is, what about the pollution that's in the air? So one of the things that we did with a very good friend, Fleming Cassie, from the Netherlands, he works at the Departments of Health there in the Netherlands, is that he has what he calls the MAP cell. And in fact, the MAP cell is due to arrive back in Edinburgh next week for us to continue our research. But basically, it's a mobile exposure laboratory. And in fact, here's the Royal Infirmary site where I'm mostly based, although I do work at the Western St John's as well. And this is the exposure chamber. This is actually parked outside the accident emergency department, you'll be pleased to hear, directly opposite the hospital. And what we did was do some controlled exposure studies inside. Now, inside it looks a little bit like this. So on the right it looks a bit like a missile launcher, but it's actually, what it does is it's a hoover that sucks in the air, and then it concentrates the particles. And then you can see it's rather a bizarre appearance here. We haven't modified it to make it look a little bit more aesthetically pleasing, but in the actual exposure chamber, which is all in the same trailer, if you like, of the lorry, so it's quite compact, we expose healthy volunteers and patients to different forms of pollution. And we've done various different studies looking at what may or may not cause problems. So one of the first studies that we looked at was just using the air particles in the air. So we looked at concentrating what the particles in and around the Royal Infirmary. Now there are some buses that go past, so we were hoping there'd be quite a lot of bus combustion in there. But when we looked at the vascular stress test, after we concentrated the air particles and gave it to the volunteers, we did not actually see any effects on this vascular stress test. So as you can see, the lines here are identical. CAPS stands for concentrated ambient particles, so the particles in the air. Now, we were a bit disappointed about this. We did, however, have a smart move in that at the time, through a collaboration with chemistry, there was an aerosol time of flight mass spectrometer on the campus. It's normally in Birmingham, but it happened to be in Edinburgh. So what this is basically it takes particles and then annihilates them with a high-powered laser to its elemental components. So you can tell what the physical chemical structure of the particles was. And when we did that on 8 days when we're doing these exposures, demonstrate quite beautifully that Edinburgh has an awful lot of particles in the air that are sea salt. So the pale blue there is sodium chloride, and blue is aged sodium chloride. So the pale blue and the dark blue is basically sea salt. And of course, Edinburgh is a coastal city. And as my daughter is demonstrating on Blackford Hill way back then, you can just about see the Firth of Forth. So even though we're at Little France site, the prevailing weather conditions meant that mostly in Edinburgh, what we were experiencing was actually sea salt and not anything noxious. So people say it's always good to go and walk in the sea breeze and it's healthy for you. Well, it's not unhealthy for you, that's for sure. It doesn't actually say it makes you any better, but it's certainly not unhealthy. So, and that's part of the problem with exposure studies when you're sucking in the air. You're very much at the mercy of what happens to be happening with the prevailing wind, the weather conditions and things like that, because rain certainly can bring out, tends to lower air pollution because it catches the particles and takes them out of the air. And so what you really need, if you're going to study these sorts of things, is stick right by a road. And we obviously weren't close enough to the road, and the emergency department's obviously a healthy environment. But this is a sort of a heat map of central London, if you're actually looking at where the air pollution is. And you can see that it just basically goes where all the junctions are, where cars stop in traffic, at the crossroads, and where they're idling. So air pollution is very much at that. And I actually went down to London in 2007 with a backpack on my back to monitor it as I went around London. Now, you may remember that July that year wasn't a good year for wearing backpacks in the centre of London, and I was a little bit anxious that this machine on my back humming away, going in the underground and on the aeroplane, that someone might accost me, but they didn't seem too bothered. But this just shows you sort of a histogram of what happens to pollution. Now, the first day I went in November, it was raining a lot. And it comes back to this bit of precipitating out the air pollution. You can see that actually the levels of air pollution was modest. But when a bus went past and I was stood at a crossroads, you can see it spikes quite a bit. The underground has quite a lot of particles in the air, but actually they're thought to be, let's use my words carefully, thought to be rather innocuous because it's often brake particles that are thrown up into the air. This is an area of interest, but generally speaking, there are lots of particles in the air, but they're not really combustion derived. that we see with road traffic. And here I went past, I think it was a hot chestnut stall cellar, and you can see I've got quite a lot of exposure there. This is on a dry day walking down Oxford Street, and you can see the levels of air pollution are much higher. So of course London has introduced a congestion charge in an attempt to reduce it. I don't think it's made a huge impact on air pollution levels, I have to say. One approach though is to use particle traps. Now these can be fitted to diesel engines, and in some countries they're not quite mandated, but you can get grants to do it. But certainly you can put a particle trap on your diesel engine to get out the diesel particles. Now, I'm not being mean to diesel engines, because diesel engines on the one hand are more efficient, so they're producing less CO2, but on the other hand they produce a lot of particles. And so there are pluses and minuses there. But we thought about, well, can we prove whether this actually makes a difference or not? So we repeated our vascular stress test studies in Sweden and also here in Edinburgh, where we used particle traps to try and take out the particles and see whether the blood vessels were better or worse when you had a particle trap in. And as you can see, the amount of particles we could reduce many orders of magnitude by putting a particle trap in. It's very effective. And look at the mass, it's almost 200-fold lower. And when we did this, compared to the diesel, so that's diesel, and then that is the filter, you could see that you actually seem to get a beneficial effect. And perhaps a nicer way to look at this is that clot chamber that I showed you. So here you've got air, here you've got diesel, so you get more clot. Here you've got diesel, and then when you filter the diesel and take the particles out of the exhaust, you seem to produce less. So it certainly seems to suggest to us that the particles seem to be causing the problem, and if you filter them out, and you can leave the gases potentially, if you filter them out, then actually the air pollution effect isn't seen or as obvious. Now, you'll be beginning to wonder whether I'm ever in Edinburgh, but one of the things that we wanted to look at was really try and look at other countries in the world, because in Edinburgh and other places, the actual air pollution levels aren't that bad. So here's an example. These are average levels, don't forget. So London is at least twice as bad as Edinburgh, but it's still, the average levels aren't too high. Now remember, I was talking about 300 in that chamber. Now air pollution in Beijing is much higher, and this is average, daily averages across a year, the official daily averages. You will probably be familiar, there was a bit of a furore around the Olympic Games a good number of years ago, 5 or 6 years ago, when they were being held and commenting on the air pollution. So we actually went out just before the Olympics. I tried to stay for the Olympics, but unfortunately I couldn't stay for the Olympics. And Jeremy, who's a cardiologist here in Edinburgh, went with me and Nick, and we went with my backpacks that I had, and we started to look at air pollution levels. Now, this is in the week before, week or two before the Olympic Games, and these are the levels of measured, and actually this is PM 2.5, so it's this slightly smaller size. And the relationship between the mass is actually, if you go from PM 10 to PM 2.5, you can probably roughly halve it. So a PM 10 value of 300 is the same as of 150 of PM 2.5. And this is PM 2.5, and look at the number here, it says 400. 400's around here, so sometimes getting up to 500 micrograms per meter cube. So the equivalent in my chamber in Sweden would have been 150, because it's half as much. So that's down here. That's down here. This is the WHO standard for what air pollution should be, right down here. The air was thick with actual, and when Jeremy was there, I kept saying to him, the machine's broken, you need to recalibrate it. He says, I've recalibrated it twice, it's fine. The air pollution levels were really quite dramatic, and we did sample some of the air. And here you can actually see physically what it looks like, some of the coarse fine and ultrafine. And it looks rather reminiscent to me of the tar that people used to show from smokers' lungs. You can really see quite a dramatic amount of quite potentially toxic compounds that are in the air. When the Olympics actually happened, because we weren't allowed to do any research while the Olympics were happening, the ethics committee was asked if they would mind, and he came back and said no, not just now, not while the Olympics were on. I think they were very sensitive to what was going on and didn't want any adverse publicity. So we went back after the Olympics to do it, and I could understand why they were sensitive to it. But actually during the Olympics, the air pollution levels weren't that high, and that's because it rained. And it does tend to rain in Beijing at that time of year in August. and the air pollution levels are at their lowest. And it's not any badness necessarily, I would also say, about Chinese factory or town and country planning. In Beijing, they're surrounded by a large mountain range, and it's a natural sink for air pollution to just sit there. And that's the problem that they struggle against, is that the climate around them is adverse, and it just meant to let it sit there. A bit like sometimes San Francisco and Lima tend to be a bit smoggy and foggy at times, because it's just the way that the geography and so on happens. Anyway, so we started to do some studies. As you can see, I'm modelling again, and we got these backpacks, and we took around 100 patients in Beijing and got them to walk with and without wearing an intervention, which was a face mask. Now, face masks, of course, in Asia are quite popular. You often see people walking around with face masks on. The vast majority of the ones you see are a complete waste of time, because I don't know whether you can see some of these ladies here, but they often have a big, it's over their nose, but it's got a big open air around the side, and air just gets sucked in down the side. It doesn't really filter anything out to any great extent. So we didn't use those simple cloth ones. We did actually test quite a range of them. And the best one actually was a £1.50 3M industrial mask, which seemed to, if you get it fitting tightly around the nose and mouth, it's actually a very efficient particle trap, and actually removes not over 96% of the particles in the air. So what we did was we gave people a face mask to wear one day, and then just walked without a face mask another day. So they didn't know whether they had one or not. But when you asked them, and if I asked you when you were walking through a hot inner city street with a mask on, whether you found it comfortable or not, you would probably predict you'd say no, it wasn't very comfortable, it's hard to breathe. But actually, they felt it was easier to breathe with the mask on, and that their irritation and things like that were much less. They coughed less, they seemed to breathe better. Now, that might be a huge placebo type effect where you've prejudged the situation. I've got a mask, and we are actually going to replicate that with a sham mask. So we're going to have two masks, and one we're going to take the filter out without telling them too much. I suspect you might feel the resistance is slightly different, so it's not going to be perfect, but I think we'll also try and do that. But when we did that with people, we monitored them quite closely and looked at their blood pressure and heart rates. And when they wore the mask, their blood pressures were lower. And again, we did the measurement of how stressed the heart is, and the ST segment depression, that thing that just a barometer of how stressed out the heart is, was less when they wore the mask. Now, I would have thought that if you're working harder, breathing harder against a resistance with a mask on, perhaps that might be the other way around. So in some senses, I'm quite encouraged by that. It seems that if you stop a chronic exposure or intermittent chronic exposure with a face mask, it does seem to get some benefit. Now, not for a minute advocating everybody goes around wearing a face mask, and certainly the levels, as I've shown you in Edinburgh, are far, far lower than you'd ever see in Beijing. I'm also not suggesting that when you go to Beijing you necessarily need to wear a mask, but these are just some of the things that we're trying to tease apart in terms of working out whether what interventions we can do to try and reduce the risk. So we should come back to Scotland, and I suppose there was, in actual fact, a nice public health experiment that was performed in March 2006, because as you know, we had a smoking ban in Scotland, and there was lots of, I think, resistance to that, and I think it was to Scotland's credit that it pushed ahead and forged ahead and did it rapidly. And I think we're much better off for it. And the reason I say that was because Jill Pell, who's a public health professor in Glasgow, managed to convince the Scottish Government to allow her to do a survey in the year before the implementation of the ban and the year after the implementation of the smoking ban, and count how many people came into the hospitals, 10 hospitals across Scotland, with a heart attack. And she looked at them the year before and the year after. What you can see here is in the pale bars is month by month rates of heart attacks in the year before and the year after the smoking ban was introduced. And this reduced heart attack rates by about 17%, which might not sound a lot, but on a population level that's a huge amount. And that is quite a massive reduction. Now, there had been some reports before about that type of effect, but basically they didn't do it in a systematic way. We got levels of spit and saliva to look at the cotinine levels in the blood, and we were able to look at smoking status and all of that. And it really was quite a dramatic reduction that we saw in myocardial infarction. And in fact, it wasn't just myocardial infarction, it also occurred with stroke. This is a slightly different way of presenting the same data, but you can see the incidence of stroke, and then the smoking ban comes in, you can see it dip. So stroke is like a brain attack, if you like. It has many similarities with heart problems. So I've whittled on for about 3/4 of an hour now. I should perhaps pause. I hope I've convinced you that there's a very tight relationship between air pollution and heart attacks, be that self-induced or environmental. I think I've hopefully convinced you not only do we have the epidemiological data, which may have issues in terms of confounding, that I've linked it with the mechanism of what we think is causing the heart attacks, both for smoking and air pollution, in that we think the blood vessels are impaired, they don't relieve as much of this clot-dissolving guardian protein, and they're much more likely to let blood clot. And we think the principal cause for the environment is related to traffic-derived, combustion-derived air pollution particles. And if we take those out, actually we can get rid of some of the adverse effects. And I suppose the real public health message is that we should continue to strive to reduce particles in the air pollution from combustion-derived sources such as cars to really help improve the health of the country. I think obviously it's challenging in economic climates, in economic countries that are rapidly industrializing. But these countries also have escalating rates of coronary disease, of heart attacks, and perhaps there's no surprise of that association. Finally, I just want to thank all the patients that helped with that and their time. We gave very generously of their time, and they volunteered to help support the research. And I also want to acknowledge that I didn't do this on my own. There was an awful lot of people from here in Edinburgh, also the Netherlands, particularly Sweden, with my great friends in Umea, but also chemistry and also Mount Sinai in the USA and Glasgow. Thank you for your attention.
Thank you very much, Dave. Well, that's a very interesting exposition of a lot of problems. So who's got a diesel car? Yes, one or two of you owning up. So do you think we should now have compulsory catalytic converter equivalents to clear up the pollution from the diesel?
I think it is quite a simple mechanism, and actually a lot of the car manufacturers have been testing in Sweden with the facility up there to look at particle traps efficiencies. And actually, it will cost extra, but it's actually, if you put it as part of a manufacturing production line, after the initial investment, it'll actually be very cheap and very reasonable. So I think that we've seen emissions being monitored more and more tightly. And I would like to see a situation where it is mandated that all new diesel engines have particle traps.
What advice would you give to a sedentary businessman who's a non-smoker, who is from the UK, not necessarily Scotland, who's within his normal body mass index parameters, about the sort of car or transport he should be taking to work? Should he have his BMW that's diesel, underground? Should he be on his bike with a mask?
He should be on his bike. This is my bike helmet. Prop number one. He should. Now, there is an interesting bit about cycling in traffic, because you will be aware that most traffic lanes for cyclists share with buses and taxis, which I think is not great for lots of reasons, partly to do with trauma of being run over, but also they're just the engines, cars and vehicles that have diesel engines. So it's a bit unfair, really. Having said that, there's a few little things that are quite intriguing. So if you actually look at air pollution inside a car, and you measure the particles, often the air intake's at the front, at the floor level, which is right next to the tailpipe of the exhaust pipe in front. So actually, if you measure inside a car, the pollution levels are often higher inside a car than outside the car. And sometimes, you know, some of the manufacturers have actually been testing cabin filters to see if you can filter out that exposure. So when you're tootling along in your car, you're actually probably got more air pollution if you measure the amount in the air than if you're out on your bike outside. Now the problem with being on your bike outside is that you aren't just sitting there pressing buttons on turning a wheel, you're actually exercising. So your ventilatory rate, your breathing rate, goes up 3 or 4-fold. So actually your overall exposure is probably the same sitting at a wheel as it is on a bike. The only thing is that on a bike you can feel a bit more self-righteous and proud of yourself than if you're in a car. And also you talked about a sedentary person. Well, my advice would be to get on your bike and to cycle, because number one, it's good for everybody else.
If you're a taxi driver?
A taxi driver? Well, you don't want to get knocked off your bike, but if that's what you mean. Sorry, more questions.
Dave, one of the big issues in air pollution is nitrogen dioxide.
Yes.
And as you know, the epidemiology says that's almost as bad as particles. And they correlate very closely with ultrafine or nanoparticles. Have you any experimental evidence which gives you clues on that?
Yeah, a great question, Andrew. So nitrogen dioxide is predominantly generated by combustion engines, cars. So when you see high pollution levels, the nitrogen dioxide levels are high. And so they tend to track with each other. So to try and work out which one's causing which can be a problem. Now, we have looked at this specifically. So we have taken healthy volunteers and given them nitrogen dioxide gas and looked at their blood vessel function, and we could not find any problem. We've also filtered out the particles and just given the gas, and we've also given just pure particles that aren't combustion, they're just carbon particles, and we don't see an adverse effect. So we don't think it's the nitrogen dioxide on its own. Now, the combination of nitrogen dioxide with particles could be even worse than just particles on their own. We haven't assessed that. But I do think it's guilt by association, is my personal view, and I don't think it's a mediator.
Thank you, I agree with that. but it's costing an awful lot of money for local authorities to
Yes.
to comply with regulations
Yes.
on
And I
NO2.
think it's ill-targeted. You're right.
There we go.
Yeah, how do petrol engines compare with diesel?
Good question. So the amount of particles they generate is said to be around 50 times lower. So the mechanism of combustion and so on and so forth. So for petrol engines, they tend to generate less particles. Still generate them, but not to the same extent as diesel.
Sorry, 50 times lower, or
Yes,
50%?
50 times. Sorry,
Yeah,
50
yes,
times.
Yeah, a huge difference.
Yes, absolutely.
Yeah.
More than an order of magnitude difference.
You mentioned stroke as having some obvious similarities with heart disease and possibly having the same sort of etiology. But the big killer that you didn't mention, of course, is cancer. And I mean, the obvious connection between smoking and cancer has been made laboriously for many, many years. But what about the other cancers and the kind of pollution that you're talking about? Do you have any links to cancer research that you can tell us about?
I'm afraid I don't have any links to cancer research as such. I mean, some of the early data did come out of people trying to find out some of the data around cancer, and this is where the cardiology world really came into its own. I think the association of death is predominantly due to cardiovascular disease, so heart trouble, that sort of thing. The links with cancer are more difficult to do, and I think in the early days of the smog, etc., people thought that that's where all the lung cancer was being caused by, but actually it was cigarette smoking, as you know, that was the driving force. That's not to say it didn't contribute, but the vast majority of it is related to cardiovascular disease. That's the biggest and most dominant factor.
You mentioned the reduction, almost 96% reduction in TPA of smokers, but you've talked about blood vessel function as well. So is there a correlation between air pollutants and, say, blood pressure or other aspects of...
A very good question. And the problem with blood pressure, it does vary quite a lot during the day because of you exercising and doing things. Rob Brooke, who works in Michigan, I'll get it right in a minute, is a big expert on this, and he's demonstrated quite nicely that particularly diastolic, the lower part of the blood pressure goes up when you're exposed to pollution, and also the systolic, and actually he's got quite a big paper which he hopes is coming out soon demonstrating this. And blood pressure effects, of course, just a small amount might seem, well, it's only a little bit, but actually that can have a huge effect, and of course there's a range of effects that it can have on people. So we have certainly seen constriction, I mean tightening of blood vessels, and there are modest effects on blood pressure, and we've seen a reduction when we intervene on it, and he certainly described quite nicely that blood pressure can go up when you're exposed to it. So yes, there are blood pressure effects.
I know you mentioned that ex-smokers are hard to tease out from sort of still smokers, but is there any sort of similar trend? Do things get better after time?
Yes, they do.
Stop?
So the good news for smokers is if you stop, your risk of a heart attack goes down almost to non-smoker levels within about a month or two. Now that's not true for lung cancer because that can go on, that can last for 10 years. But for heart attacks, it comes down very, very quickly and within a month. So it's never too late to stop smoking for heart trouble.
And are there similar effects, to passive smokers? Do you see similar trends? Or
That is certainly meant to be the case, and certainly if you were to, that's the natural corollary of what I showed you with the smoking ban studies, that it really does fall very rapidly. And the other thing I often say is that half the risk of smoking is in the first cigarette you take. So when I see patients in the clinic and they say, oh, well, I used to smoke 30, but now I only smoke 2, I'm a bit of a misery, actually, because I point out to them that's no good. Because you might as well smoke, well, I don't say you might as well smoke 15, but I say to them, no, you really have got to stop. And that's, of course, why there's such a strong signal with passive smoking, because that very early burst of very small amounts actually carries half the risk.
Please.
Hi there. You have established the correlation between the particles and the heart disease really well. I was just wondering if you can quickly explain the internal effects and actually how the particles affect the blood flow and the clotting sort of on a biological level.
Yeah, excellent question. So you're breathing it in. So how does it affect your heart artery that's right in the blood circulation? So there are several theories about this. Some people in the room have written about this. The classic mechanism is that you cause inflammation in the lungs, which then spreads to the body, and that might be through blood-borne factors, so hormones that might get released. It might be through cells that have been wound up that then go into the circulation. One of the things we're quite interested in at the moment is the concept that actually the particles might get into the bloodstream themselves. And these are nanoparticles, so they're really tiny, and they can slip across, we believe, membranes through the lungs into the bloodstream directly. And one of the best known nanoparticles about the same size as air pollution particles is something called LDL cholesterol, which is a tiny packet of fat. And LDL cholesterol is a nanoparticle, and that tends to eddy out in areas of the artery, which then causes this fat deposit in the wall of the artery. So one of the concepts that we're toying with is if these tiny particles, which have lots of potent chemicals on them that might cause problems, were to get into the bloodstream, they would then, you would predict, eddy out in areas where there is plaque, this disease, this furring up of the arteries. So one of the things we're doing a gold study, we're calling it at the moment. So we're going to produce a cloud of nano gold, which sounds like it's going to be expensive, but because they're so nano, it's not a huge amount of gold. Why are we using gold? Well, two reasons. One, it's inert. Gold, as you know, doesn't change. That's why you use it as jewellery. And in the body, it doesn't cause any toxic effects. But also, your body doesn't really have any gold. So if we expose people to it, and then we take blood samples, and then one of the things we're trying to do is to get hold of some samples of tissue with this fat deposit in, and show there's gold in it after they've breathed it in, we can prove that those particles have gone into the bloodstream. Now, people have sometimes tried that with radioactivity and things, and I won't bore you with the technical details, but it's proven so far very hard to prove. We've done some work, from basic science work with animals, where looking at this, But it does seem that these particles can indeed get entry to the bloodstream. And we believe that that might be part of the answer. So 2 answers. 1, causes a lot of problems in the lungs, winds up cells, lots of inflammation. 2, we think these particles might actually get into the bloodstream and cause harm actually at the site of that we've been talking about.
As someone who has had a heart attack on visiting London for professional purposes, I have an interest in the answer to this, and I did a study, a repeat study, in which I found no effect of air pollution in a group of patients who were in or had had heart failure. And I think the reason is that they're on good treatment.
Yes.
And I just wondered if you'd got any comments on the effects of statins, for example, on air pollution type or particle type effects.
Yes. I mean, that is an area of big interest, and I suppose as doctors we like to give tablets out and rather than actually nail their root cause. But in a pragmatic sense, if you've got someone with heart disease and they're vulnerable and at risk and you can't do anything about the air they breathe, then that would be a logical extension of that. We have not done any statin studies as such. We have looked, I mean, most of the patients that we did in our studies, we made sure they were on best treatment before studying them because we wanted to do that for obvious reasons. So we haven't really delved into, is there a statin effect? And of course statins do have anti-inflammatory effects as well as lipid effects. So that is an obvious one. Another one that has been mooted has been using antioxidants like vitamin E and C. But the trials for that, of course, have been resoundingly negative. And I'm not sure that it's as simple as just giving an antioxidant. I think it's more what's happening at the cell level and the local environment that determines that. But it's an interesting thought. Interesting thought.
I'm quite intrigued. What effect will, obviously, this vaping business, the nicotine substitutes? I mean, my atmospheric geography experience is that in order to get a vapor, you've got to have a particle in order for the water to be able to form a vapor globule. How have the Food and Drug Safety Regulatory Authorities allowed vaping when the kind of research you're coming out with now, and how long will it be before we'll get an answer?
I'm afraid I can't give you a straight answer to that one. I actually don't know. We haven't done any research in that area. Obviously, from my perspective, I'd rather someone give up smoking completely, and if that's a crutch they need to get to their end game, then great. And it's obviously not something necessarily. We have looked at nicotine. So we have done some studies with nicotine patches and so on and so forth, and we've not seen any adverse effects in the blood vessel stress test that we've used. So nicotine in itself seems okay, but you're raising the issue about the e-cigarettes and the vapors and things like that, and I can't give you a straight answer because we don't know. We don't know.
There's a question over there, and then there's one in front.
E-cigarettes being used in closed rooms with no windows.
So I suppose it comes back to the same question, but my understanding of e-cigarettes is they're not producing combustion, which is the important aspect. It's a vapor, which is moisture, if I understand them correctly, and that is a big if. But if it's a moisture, water, then that shouldn't be harmful. What we're talking about here is nanoparticles, which are almost like a gas, but they're really tiny, but they're particles, they're solid matter. And my understanding of e-cigarettes is that they're generating mostly vapor, which is water, a bit like smog and mist. So that shouldn't be harmful. And I've already told you that rain actually tends to precipitate out air pollution. So it's a very different mechanism. Of course, people are rightly anxious about the safety of these e-cigarettes. But as I say, I'd rather someone tried something and got off smoking than not.
There's a last question, gentleman there.
Coming from Scandinavia, from Norway, we have this substitute for cigarette. Yes, and I wonder if you know anything about the effect of snus regarding to what you're talking about.
So snus, for those of you who don't know what this is something you see in Sweden and Norway. And it's like a little tea bag almost, but it's got chewing tobacco almost in it. And you snick one off under your lip, and they come in different flavours, lots of nice exotic flavours. So you can have peppermint and all sorts. But it's a habit that has been used. And people have used it potentially as a nicotine substitute, and people have suggested it might even help people stop smoking. Now, because of our Swedish connection, we have looked at this. So we did do some studies with snus, and we didn't really see any major bad effects. It did change blood pressure and heart rate a little, but in terms of the stress test that I've told you about, we didn't see a big effect.
So we've had a fantastic lecture. We've learnt an awful lot about heart attacks, about how smoking does bad things to your blood vessels and causes all those little clotty things to form and the blood vessels to respond in a bad way. And now we hear that nanoparticles coming out of diesel exhausts are bad for us too. Well, that's one up for the tram. For those of us who suffered all those splendid tram works that seemed to go on for decades, but apparently it was a little less than that. So I've certainly learnt an enormous amount. I'm still perplexed about how the tobacco industry manages to persuade us, the public, to actually use its product when the statistics tell us very clearly that half of us will die prematurely from using it, and yet apparently it's a sale. So 25% of us still take part. We'll learn soon from work that Dave's been doing and others how best to deal with particulates from motor vehicles and industry. But you've learnt, and I've learnt, an enormous amount. So I would like, on behalf of everyone, to thank Professor Dave Newby for a splendid talk, and I'd like to do that in the conventional way.